Hello, dear students. Let's continue with chapter 52. Right now, we are going to study ulcerative colitis and Crohn's disease. Look at this table. Ulcerative colitis begins in the rectum and proceeds in a continuous manner towards the cecum. Okay? That's why I usually remember this by the U is the ultimate part of the column to the C to the cecum, ulcerative colitis. Crohn's disease is most often in the terminal ileum, with patchy involvement through all layers of the bowel. Okay. Um, another piece of information that is good to remember to make a difference. In ulcerative colitis, you're having 10 to 20 liquid bloody stools per day. 10 to 20 bloody stools per day. In Crohn's disease, 5 to 6 soft, loose stools per day, non-bloody. Okay? Crohn's disease, non-bloody, ulcerative colitis, bloody stools. Complications of ulcerative colitis, of course, hemorrhage. And of course, this is going to bring as a consequence nutritional deficiencies. And in Crohn's disease, fistulas and nutritional deficiencies, right? Clients' needs for surgery in ulcerative colitis, 20 to 40%. In Crohn's, 75%. 75%. Even though there is bloody stools in ulcerative colitis and the risk for hemorrhage and nutritional deficiencies, the need for surgery is less than in Crohn's disease, right? Less than in Crohn's, because in Crohn's you have fistula and this patchy involvement through all layers in the bowel. So there are little pieces of cobblestone. They call them cobblestone pieces in the ileum, right? Like one piece here, one piece there, one piece here, one piece there. And when fistulas appears, that's an issue. We need to eliminate that, okay, to avoid perforation or contamination of other organs. Ulcerative colitis, pathophysiology. But before that, let's watch a video about ulcerative colitis versus Crohn's to have it clear.
Ulcerative colitis and Crohn's disease are the two major forms of inflammatory bowel disease. Both conditions are characterized by chronic inflammation of the gastrointestinal tract, or GI tract. Ulcerative colitis is limited only to the large intestine. It usually starts from the rectum and may remain confined to that location. Or it can spread upward in a continuous fashion, affecting parts or all of the colon. Crohn's disease, on the other hand, can occur anywhere along the GI tract, but it usually involves the small intestine. Most commonly affected are the end of the small bowel, the ileum, and the beginning of the colon. Crohn's disease is not continuous. Inflamed segments are usually interrupted by normal, healthy tissues. The rectum is always affected in ulcerative colitis, but is usually spared in Crohn's disease. Ulcerative colitis only involves the inner lining of the intestinal wall, while Crohn's disease extends to its entire thickness. In imaging studies, the mucosa in Crohn's disease has a patchy appearance, with alternating regions of diseased and normal tissues. The bowel wall is affected asymmetrically. In ulcerative colitis, mucosal inflammation is diffuse and uniform. The bowel wall is affected symmetrically. Thickening of the intestinal wall, Bowel obstructions and fistulas are unique to Crohn's disease. Both conditions result from an inappropriate response of the immune system, but their mechanisms are likely different. Ulcerative colitis is associated with abnormally high levels of helper T cell type 2, while Crohn's disease has more type 1 activities. Age of onset and risk factors are similar for both conditions, with a notable exception of smoking, which exacerbates Crohn's disease but has a protective effect on ulcerative colitis. The two disorders share many common symptoms, such as diarrhea, abdominal pain, and extraintestinal manifestations. However, Crohn's disease symptoms can be more variable depending on the affected locations and often include anal fistulas and abscesses. Intestinal bleeding is much more common in ulcerative colitis, while malnutrition and weight loss is more common in Crohn's disease. When Crohn's disease involves only the colon, the symptoms can be indistinguishable from ulcerative colitis. Fortunately, because treatment is similar, no distinction is necessary unless surgery is considered. This is because surgical removal of the diseased colon is curative for ulcerative colitis, but only provides temporary relief for Crohn's disease.
Wow, what a great video. What a great video. I'm so happy I posted this on our lecture. Okay, ulcerative colitis. It's a disease that creates
Irritable
what?
bowel syndrome, or IBS, is the most
Sorry. Okay, I need to control much better these technological pieces of information. Okay, ulcerative colitis is a disease that creates widespread chronic condition, inflammation of the rectum and rectosigmoid colon, but can extend to the entire colon when the disease is extensive, associated with periodic remissions and exacerbations. Many factors can cause exacerbations, including intestinal infection. Older adults with UC are at higher risk for impaired fluid and electrolyte balance as a result of diarrhea, including dehydration and hypokalemia. The intestinal mucosa becomes hyperemic, has increased blood flow, edematous, and redness. So the patient stool typically contains blood and mucus. Blood and mucus. Patients report tenesmus, an unpleasant and urgent sensation to defecate, and lower abdominal colicky pain relief with defecation. Tenesmus also is a symptom that many people with constipation has, right? So if you're having constipation after you feel that you finish your bowel movement, after that you are still having this a sensation that you need to defecate even more. Malaise, anorexia, anemia, dehydration, fever, and weight loss are common. Extra-intestinal manifestations such as migratory polyarthritis, many joints, ankylosing spondylitis, and erythema nodosum are present in a large number of patients. And of course, we have a video to double check what is, for example, the erythema nodosum. Let's see. Oh. There you go, inflammatory bowel disease, sarcoidosis. Thank you. So you know where is erythema nodosum. And right now, I want you to see also the other piece of information. Ankylosis spondylitis. Anky means crook, bent, or stiff. Losis, problem. Spondy, spine, right? So here is the video.
Early symptoms of ankylosing spondylitis can include pain in the spine or in the pelvis, hip pain or stiffness, made worse by inactivity, the arthritis in joints, such as the shoulders, hips, knees, and ankles also can go along with ankylosing spondylitis. As the condition progresses, the inflammation of severe ankylosing spondylitis causes the vertebrae to grow together. This leads to ankylosis, which is sometimes referred to as bamboo spine.
Yes.
When the bones of the spine are cemented together, the spine cannot bend, and this results in abnormal posture. Riding in a car, standing or sitting too long may be painful due to sacroiliac joint inflammation.
Thank you. Wow. So, can you imagine all the symptoms and the pain they go through besides the gastrointestinal symptoms of ulcerative colitis, right? With the bloody stools and this extra intestinal manifestation, polyarthritis, ankylosing spondylitis, and erythema nodosum. Etiology and genetic. The exact cause of ulcerative colitis is unknown, but a combination of genetic, immunologic, and environmental factors likely contributes to disease development. A genetic basis of the disease has been supported because it is often found in families and twins. Mhm. Immunologic cases, including autoimmune dysfunction, are likely the etiology of extraintestinal manifestations of the disease. Let's repeat that. Immunologic cases, including autoimmune dysfunctions, are likely the etiology or extraintestinal manifestations of the disease. Is 24 minutes after midnight. Um, Bear with me, guys. I am a little bit tired, but we have to keep going. Okay? It's my responsibility to complete these lectures with you. Um, there is a table here, the American College of Gastroenterology's classification of ulcerative colitis severity. So you have mild when you have less than 4 stools per day with or without blood. Moderate, more than 4 stools per day with or without blood, right? So in these two first stages, mild and moderate, either they are asymptomatic or they have minimal symptoms. However, when the UC is severe, you have 6 or more bloody stools per day with fever, tachycardia, anemia, abdominal pain, elevated C-reactive protein, and or ESR. Fever, tachycardia, anemia. Yeah, because there is a lot of complications, right? Probably infection. And the last stage is fulminant with more than 10 bloody stools per day. Increasing symptoms, anemia may require transfusion, colonic distension, and X-ray, plus all the extra intestinal symptoms. Oh my God. Now, complications of ulcerative colitis and Crohn's disease. Um, Hemorrhage, perforation, of course. Toxic megacolon is a massive dilation of the colon and subsequent colonic ileus that can lead to gangrene and peritonitis, of course. Um, Non-mechanical bowel obstruction. Obstruction results from toxic megacolon or cancer. Fistulas. In Crohn's disease, in which the inflammation is transmural, fistulas can occur anywhere, but usually track between the bowel and bladder, resulting in pyuria and fecaluria. Colorectal cancer. Patients with ulcerative colitis with a history longer than 10 years have a high risk of colorectal cancer. Extraintestinal complications include arthritis, hepatic and biliary disease, especially cholelithiasis, which is stones in the gallbladder, oral and skin lesions, and ocular disorders such as iritis. The cause is unknown. Osteoporosis. Osteoporosis occurs especially in patients with Crohn's disease. Pyuria is the presence of pus in the urine, typically from bacterial infection. Okay, let's continue. Ulcerative colitis is more common among Ashkenazi Jewish individuals than among those who are not Jewish, and among white more than non-white. Incidence. In the United States, 1.6 million individuals are affected by chronic inflammatory bowel disease. Between the two primary types of IBD, ulcerative colitis and Crohn's disease, the incidence is split among almost equally. Although diagnosis can occur at any age, most people are diagnosed between 15 and 35 years of age. Wow, 15 and 35 is the beginning of the life, right? Women are more often affected than men in their youngest year, but men have the disease more often as middle age and older adults. So during the assessment, when we collect history, we need to ask about the family history of IBD, current therapy for the illness, dates and type of surgery, obtain a nutrition history, intolerance of milk, milk products, and fried, spicy, or hot foods. All the all these nutrients, of course, are going to cause damage to the mucosa, uh, intestinal mucosa, right? Usual bowel elimination pattern, abdominal pain, tenesmus, anorexia, and fatigue. The signs and symptoms during sorry. Signs and symptoms during our physical assessment. Vital signs are usually within normal limits in mild disease. In more severe cases, the patient may have a low-grade fever. Viral and bacterial infections can cause symptoms similar to those of UC. Note that abdominal distension along the colon, fever associated with tachycardia may indicate dehydration, peritonitis, and bowel perforation. Assess for signs and symptoms associated with the extraintestinal complications such as inflamed joints and lesions inside the mouth. Psychosocial assessment, anxiety, because the fear of fecal incontinence resulting in feeling tied to the toilet. Of course, it's if they are going to have more than 10 stools per day, with or without blood. Remember the table we just saw. Um, this patient needs a lot of support, right? The relationship of life events to disease exacerbation. We need to consider all these factors. Stress factors that produce symptoms, family and social support systems, concerns regarding the possible genetic basis and associated cancer risks of the disease, internet access for reliable education information, laboratory assessment. Hematocrit and hemoglobin levels may be low, related to chronic blood loss, which indicates anemia and a chronic disease state, and increased WBC count, C-reactive protein, which is a marker for inflammation, or erythrocyte sedimentation rate, another marker of inflammation. is consistent with inflammatory disease. Blood levels of sodium, potassium, and chloride may be low as a result of frequent diarrheal stools and malabsorptions through the diseased bowel. Hypoalbuminemia, decreased serum albumin, is found in patients with extensive disease from losing protein in the stool. Losing protein in the stool. Other diagnostic assessment, magnetic resonance enterography is the main examination used to study the bowel in patients who have chronic IBD. Teach the patient that he or she will need to fast for 4 to 6 hours before the test. As part of the test, the patient drinks a large amount of contrast medium. This can cause abdominal discomfort and diarrhea. And all these factors needs to be explained to the patient before the procedure. Be sure that the patient has the opportunity to go to the restroom before positioning on the MRI table. And don't be surprised that during the examination, more bowel movement will come. An upper endoscopy and or colonoscopy may be done to aid in diagnosis, but the bowel preparation prep can be especially uncomfortable for patients with inflammatory bowel disease. In some cases, a CT scan may be done to confirm the disease or its complications. Barium enemas with air contrast can show differences between UC and Crohn's disease and identify complications, mucosal patterns, and the distribution and depth of disease involvement. So I have a video for barium enema. To have it clear, right? We need to have these procedures clear in our mind.
A barium enema examination, or lower GI series, is an X-ray procedure used to visualize the interior anatomy of your large intestine, or colon, and rectum. Your digestive tract consists of the mouth, esophagus, stomach, small intestine, colon, and the rectum. Food travels down the digestive tract in this order. The main functions of the colon are to absorb water into the body, change liquid waste material into solid waste material known as feces, and store feces until enough accumulates to be passed from the anus as a bowel movement. Abnormal conditions may develop in your colon, such as colon cancer, polyps, outpouchings of the colon wall called diverticula, ulcers, or narrowed areas known as strictures. If you develop unexplained bleeding, abdominal pain, or change in your bowel habits, your doctor may recommend you get a barium enema examination. Before the procedure, you'll be asked to lie down on an X-ray table. A lubricated tube will be carefully inserted into your rectum. A bag containing barium will be attached to the tube, and the barium will be allowed to flow into your colon. When enough barium has flowed into your colon, you'll be asked to try very hard not to expel any of it while X-rays are taken. A tiny balloon attached to the tubing that carries the barium may be inflated to prevent any barium from leaking out during the exam. While the X-ray pictures are being taken, you'll be asked to roll from side to side or to stand up. This lets the barium flow to different areas so that sufficient X-ray images can be obtained of your entire colon. After many X-ray pictures are taken, you'll be given a bedpan or taken to a bathroom and asked to expel as much of the barium as possible. A few more X-rays may be taken after you have passed most of the barium out of your colon, because the small remaining amount of barium clearly illuminates the outline of your colon. After your barium enema, you can go home. You will most likely be able to resume your normal diet. Most radiologists instruct patients to increase their fluid intake for a period of time to be certain all of the barium is passed. You will likely notice more gas than usual and see barium in the next several bowel movements that you pass.
Thank you very much. Okay. So, let's see. Okay. So, an upper endoscopy and or colonoscopy may be done to aid in diagnosis, but the bowel preparation prep can be especially uncomfortable for patients with inflammatory bowel disease. In some cases, a CT scan may be done to confirm the disease or its complications. Barium enema with air contrast can show differences between UC and Crohn's disease and identify complications, mucosal patterns, and the distribution and depth of disease involvement. So, the priority collaborative problem for patients with UC include diarrhea due to inflammation of the bowel mucosa, acute or persistent pain due to the inflammation and ulceration of the bowel mucosa, potential for lower GI bleeding and resulting anemia due to UC. Correct. Managing diarrhea with the non-surgical management includes drug and nutrition therapy. The use of physical and emotional rest is also an important consideration. Teach the patient to record colon, volume, frequency, and consistency of stool. The color is very important. I explained to you the other day. The type of stool determines the type, how is your health. Monitor the skin in the perineal area for irritation and ulceration resulting from loose, frequent stools. Have the patient record their weight 1 or 2 times per week. Drug therapy. Common drug therapy for UC includes aminosalicylates, glucocorticoids to reduce inflammation, antidiarrheal drugs, and immunomodulators for the immune system. Teach patient about side effects and adverse drug events. Sulfasalicylane, the first amino salicylate approved for UC, sulfasalazine, is metabolized by the intestinal bacteria into 5-SA, which delivers the beneficial effects of the drugs, and sulfapyridine. Teach patients to take a folic acid supplement because sulfasalazine decreases the absorption. And we know that folic acid is absorbed in the small intestine, right? Especially in intestines, folic acid. Teach patient taking sulfasalazine to report nausea, vomiting, anorexia, rash, and headache to the healthcare provider. With higher doses, hemolytic anemia, hepatitis, male infertility, or agranulocytosis can occur. This drug is in the same family of sulfonamide antibiotics. Therefore, assess the patient for an allergy to sulfonamide or other drugs that contain sulfa before the patient takes the drug. The use of thiazidiuretic may be a contraindication for sulfasalazine. Agranulocytosis is a condition in which the absolute neutrophil count, the neutrophil, is less than 100 neutrophils per microliter. Okay, so I want you to remember that. It's very important. Okay, here is microlite of blood. People with this condition are a very high risk of severe infection. Normal 2,500 to 6,000. That's the normal count of neutrophil, the normal number of neutrophil count. Okay. mesalamine, glucocorticoids, we spoke about that, to provide symptomatic management of diarrhea. Antidiarrheal drugs may be prescribed. Immunomodulators are drugs that alter an individual's immune response. Nutrition therapy and rest. Patients with severe symptoms who are hospitalized are kept MPO to ensure bowel rest. The primary healthcare provider may prescribe total parental nutrition for severely ill and malnourished patients during severe exacerbations. Some patients with ulcerative colitis find that caffeine and alcohol increase diarrhea and cramping. Mm. For some patients, raw vegetables and other high fiber foods can cause GI symptoms. Lactose containing foods may be poorly tolerated. Let me stop here let me talk about raw vegetables. Some raw vegetables could be in the family of the broccoli, the brassica. They call it brassica vegetable. The broccoli, the cabbage, the Brussels sprouts. Okay, can cause gas and cramping. Lactose containing foods may be poorly tolerated and should be reduced or eliminated. Teach patient that carbonated beverage, pepper, nuts, and corn, dry fruits, and smoking are common GI stimuli that could cause discomfort. Interesting. Nuts, dry fruits. Each patient differs on his or her food and fluid tolerances. Okay. Um, let's review this about the TPN. A person who is in total parental nutrition receives all the nutrients and energy they need through an intravenous IV line. The nutrients enter through the veins and travel through the blood vessels to the entire body. So this is TPN. If you need a refresh, there you go. You have it there. Um, It is very important for the patient to rest because this can reduce intestinal activity, provide comfort, and promote healing. Ensure that the patient has easy access to a bedpan, bedside commode, or bathroom in case of urgency or tenesmus. Complementary and integrative health. Examples include herbs, flaxseed, selenium, and vitamin C, biofeedback, hypnosis, yoga, acupuncture, and Ayurveda, a combination of diet, yoga, herbs, and breathing exercises. That's Ayurveda. A combination of diet, yoga, herbs, and breathing exercises may be helpful. Surgical management. Surgeries performed for complications of UC, such as toxic megacolon, hemorrhage, bowel perforation, dysplastic biopsy results, and colon cancer. Of course, they have to go for surgery. Patients who are obese, have had previous abdominal surgeries, or have dense scar tissue called adhesions may not be candidates for laparoscopic procedures. A conventional open surgical approach involves general anesthesia and an abdominal incision. Restorative proctocolectomy with ileopouch anal anastomosis. This procedure has become the gold standard for patients with UC. That includes the removal of the colon and most of the rectum. The colon and most of the rectum. The anus and anal sphincter remain intact. The surgeon then surgically creates an internal patch reservoir using the last 1.5 feet of the small intestine. The ileoanal pouch, sometimes called a J pouch, S pouch, or pelvic pouch, is then connected to the anus. In the second surgical stage, don't panic because we're going to see the pictures that are coming, okay? In the second surgical stage, the temporary loop ileostomy is closed. The time interval between the first and second stages varies, but many patients have the second surgical stage to close the ileostomy within 1 to 2 months for the first surgery. The total proctocolectomy with a permanent ileostomy. Wow. Total proctocolectomy with a permanent ileostomy is done for patients who are not candidates or do not want the ileoanal pouch. The procedure involves the removal of the colon, rectum, and anus with surgical closure of the anus. The surgeon brings the end of the ileum out through the abdominal wall and forms a stoma or permanent ostomy, right? So here we see the J-shaped reservoir. Here is the S-shaped reservoir. Look how the intestine is formed a S shape, and stage 2 after the reservoir has had time to heal, usually several months. The temporary loop ileostomy is reversed and stool is allowed to drain into the reservoir. Very interesting. Very interesting. Here we have A is a total protocolectomy with a permanent ileostomy. Okay. Then you have B, ileostomy surgical stoma placement. Here is the stoma. C, ileostomy with ostomy appliance attached. This is the appliance attached. Critical rescue. The ileostomy stoma is usually placed in the right lower quadrant of the abdomen below the belt line. It should not be prolapsed or retract into the abdominal wall. Assess the stoma frequently after stoma placement. We talk about stomas in colorectal cancer, right? Colon cancer. Recognize that it should be pinkish to cherry red to ensure an adequate blood supply. If the stomach looks pale, bluish, or dark, respond by reporting these findings to the surgeon immediately. The ileostomy drains frequently, therefore the patient must wear a pouch system at all times. The stool from the small intestine contains many enzymes and bile salts, which can quickly irritate and excoriate the skin. Skin care around the stomach is a priority. It's very corrosive, these contents. The ileostomy usually begins to drain the stool within 24 hours after surgery at more than 1 liter per day. Be sure that fluids are replaced by item 500 ml or more each day to prevent dehydration. After about a week of high volume output, the stool drainage should slow and become thicker. During this period, some patients need antidiarrheal drugs. For those who have the RPC-IPAA procedure, remind them that the internal pouch can become inflamed, pouchitis. This problem is usually treated effectively with metronidazole for 7 to 10 days. Also instruct them to omit foods that can cause odors or gas, such as cabbage, asparagus, Brussels sprouts, and beans, as I told you before. Teach patients to eliminate foods that cannot be digested well, such as nuts and corn. And of course, popcorn, right? Of course, popcorn. Managing plan. Increase in pain may indicate the development of complications such as peritonitis. We know that. Antidiarrheal drugs may be needed to control diarrhea, thus reducing the discomfort. However, they must be used with caution and for a short time because toxic megacolon can develop. Perineal skin can be irritated by contact with loose stool. We know that. Use medicated wipes. Is soothing if the rectal area is tender or sensitive from the use of toilet tissue. Preventing, monitoring for lower GI bleeding. If possible, patients are expected to remain free of complications that can cause bleeding, such as perforation or anemia. Interventions, signs and symptoms of GI bleeding. Keep in mind that GI bleeding is considered a medical emergency, therefore the patient should be monitored closely to prevent complications. We know that. Critical rescue. Recognize that it's important to monitor stool for blood loss for the patient with ulcerative colitis. The blood may be bright red, frank bleeding, or black and tarry melena. Okay. Monitor hematocrit, hemoglobin, and electrolyte values and assess vital signs. Prolonged slow bleeding can lead to anemia. Observe for fever, tachycardia, and signs of fluid volume depletion, change in mental status, maybe the first indication of dehydration or anemia. If symptoms of GI bleeding begin, respond by notifying the rapid response team or primary healthcare provider immediately. Blood products are often prescribed for patients with severe anemia. Prepare for the blood transfusion by inserting a large bore IV catheter if it's not already in place. Home care management. Those who have extra intestinal problems often need ongoing collaborative care for joint or skin problems. Home care management focuses on controlling signs and symptoms and preventing complications. Teach the patient about the nature of colitis, including its acute episodes, remissions, and symptoms management, stress. Teach patient taking immunosuppressive drugs to report signs of possible infection to the primary healthcare provider. Remind them to avoid crowds. Symptoms associated with disease exacerbation that should be reported to the primary healthcare provider, such as fever, tachycardia, palpitations, and an increase in diarrhea, severe abdominal pain, or nausea or vomiting. This is all common sense. To avoid any food that causes gas, high fiber foods such as nuts, raw cabbage, corn, celery, and popcorn. Oh, wow. Wow. I'm surprised about the celery. Teach the importance of including adequate amount of salt and water in the diet because the diversion can increase the loss of these substances. Patient and family education, preparing for self-management, ileostomy, skin protection, use a skin barrier, watch for any skin irritation, pouch care. Empty your pouch when it's 1/3 or half full. I spoke about this in the classroom. I gave an example about this. Um, Change the pouch during inactive time. Before meal, change the entire pouch system every 3 to 7 days. There's places where around the pouch area where you can put the date. Nutrition, chew food thoroughly. Be cautious about high fiber and high cellulose food. Examples include coconut popcorn, tough fiber meats, rice, cabbage, and vegetables with skin, tomatoes, corn, and peas. Drug therapy. Avoid taking enteric-coated and capsule medications for the risk of bleeding. Do not take any laxative or enemas. We don't give extra activity. We don't want extra activity in the intestinal area. You should usually have loose stools and should contact your primary health provider. Okay. Symptoms to watch. Report any drastic increase or decrease in drainage to your higher provider. If stomach swelling, abdominal cramping, or distension occurs, or if ileostomy contents stop draining. Lie down, assuming a knee chest position. Home care consideration. The patient with inflammatory bowel disease. You should assess basically pain, food and fluid intake, assess for dehydration, stress levels, availability of bathroom facilities. If they are self-manage the condition, how well are they doing with the drug therapy, nutrition, healthcare resources, social worker to arrange the service for a home care nurse. Um, we want to evaluate the patient at the end, and we want the patient to be happy, with no diarrhea or a decrease in diarrheal episodes, verbalize decreased pain, have absence of lower GI bleeding, self-manage the ileostomy or ileoanal pouch temporary. So basically, just to finish, ulcerative colitis, we have to make the patient very comfortable. Even if we control the pain and the diarrhea, remember that these patients are going to have extra intestinal symptoms, right? That ankylosing spondylitis is not easy to live with. Okay, so these patients basically need a lot of help, proper nutrition, activities that they can handle. I will add physical therapists whenever they are free of the diarrhea episodes and the pain and the absence of the GI bleeding. Some physical therapy, so some massage, that will help them a lot. They will provide some relief. And with this, we finish the ulcerative colitis topic.